Good afternoon, everybody, and thank you again to the conference organizers for the opportunity to join you all today and share some of the work that I've been involved in HIV and aging. UAB is home to many leaders in HIV epidemiological research and clinical care, and it's really a true honor to be with you all. So I have no conflicts of interest to disclose. However, I do have a disclaimer. In HIV research, the term older adult has been used to describe someone living with HIV who's over the age of 50 years. This isn't a term or a tradition I created. And actually, this definition may warrant some revision as the population living with HIV continues to age. But when I speak about older adults, that's the general age reference group that I'm referring to. So as a map of where we'll go today over the next 45, 50 minutes or so, I plan to take a hemispheric approach to discussing HIV, aging, and multimorbidity. First, we're going to start here in the US and review some of the epidemiology of aging and non-communicable diseases that we're seeing in our patients who are living with HIV. From there, I'd like to shift the focus to one that's more global, as the US and high income settings are not alone in some of the demographic and clinical shifts that we're experiencing. I'll introduce the research network that I work closely with, the Caribbean, Central America, and South America Network for HIV Epidemiology, and go into some of our group's recent work on aging and multimorbidity. Throughout the talk, I'll highlight both the challenges and opportunities for this work as we look forward. So it's no secret that thanks to the success of antiretroviral therapy, adults living with HIV are living into older ages. And it's now the case that older adults with HIV are not the exception, but rather are the majority of patients that we're seeing in our clinics. Based upon 2018 data, the CDC estimated that of all persons with HIV in the US, 51% are over the age of 50 years. While 1 in 6 new HIV diagnoses in the US are among adults older than age 50, the largest contributor to the growing number of older adults with HIV is the improved life expectancy thanks to antiretroviral therapy, or ART. These data from the Nationally Representative Consortium of Adults Living with HIV in Care here in the US and Canada, or the NA-ACORD, show the estimated number of years of life remaining from the age of 20 over 3 calendar eras. We see overall, from the early 2000s to the later 2000s, a steady increase in life expectancy. The increasing life expectancies generally occurred among most key demographics and regardless of CD4 count at antiretroviral therapy initiation. However, important disparities are easily seen in trends in life expectancy, with adults with injection drug use and individuals of racial minorities still experiencing lower life expectancy overall. A more recent analysis of these data show that since 2007, some of these disparities remain. This updated analysis from NA-ACORD data recently looked at disparities in life expectancy, now comparing 2004 to 2007 in the lightest bars, and the additional life expectancy in years 2012 to 2015 added in the dark bars. First, looking among Black and white men who have sex with men, we see a continued increase in life expectancy for both groups in the more recent years in the horizontal bars. In the vertical bars, we also see a narrowing of the life expectancy disparity by race in the more recent years, though not complete resolution. This is in contrast with the life expectancy disparity among adults with a history of injection drug use. While life expectancy has improved, shown in the horizontal bars, the gap in life expectancy between people with HIV with and without a history of injection drug use has remained constant, and that's shown in the vertical bars. And this highlights the need for ongoing efforts to reduce these important disparities. However, life expectancy and lifespan really only tell part of the story. What about health span in years of healthy life? This important study was published just last year or year before, using data from the Kaiser Permanente California and Mid-Atlantic research groups that compared adults with and without HIV in their closed healthcare network. They matched 1 to 10 on key demographics, such as age, sex, race, medical center, and calendar year at the start of follow-up. And they looked at the number of years expected to remain free of major medical comorbidity at age 20. Overall, shown in the gray lines at the top and consistent with other studies, the health span has continued to increase for people living with HIV and care over the study period. And in the end, there was only a 3-year gap in life expectancy in the persons living with HIV relative to those without HIV in the cohort. However, as shown in the orange bars below, which looked at years of expected life free of major comorbidity, people with HIV had 16 fewer healthy or comorbidity-free years than uninfected adults in the population. And this disparity remained constant over time. In fact, diagnoses of common comorbidities began on average at the age of 34 among people living with HIV. And there was no improvement in this estimate when they adjusted for time or earlier ART initiation. When they broke down by key non-communicable diseases, or NCDs, the patterns were the same. They observed that compared to adults without HIV, adults with HIV had fewer years free of liver disease, kidney disease, lung disease, diabetes, cancer, and cardiovascular disease. And again, for many of these conditions, the relative gap in age at comorbidity onset has remained constant over time. This study shows that while adults with HIV are living nearly as long as their uninfected peers, they are living with a higher burden of medical comorbidity beyond just HIV itself. Indeed, we know that a number of important non-communicable diseases are highly prevalent among adults with HIV in the US. And this graph reflects some of the reported published prevalence estimates of some of the major non-communicable diseases occurring in observational cohorts of adults with HIV in the US. It's estimated that approximately 1 in 10 adults living with HIV have diabetes, more than half have atherosclerosis, similar numbers for hypertension, and a very high prevalence of dyslipidemia. Additionally, chronic kidney disease, non-alcoholic fatty liver disease, non-AIDS defining cancers, and osteoporosis are also highly prevalent in the population. When thinking about the reasons for the high burden of non-communicable diseases in adults with HIV, there are a number of complex, interacting, but common etiologies that have been described in the literature to explain why adults with HIV have such a high burden of NCDs. First, we know that there are changes and differences related to age, sex, as well as family history and body mass index that could affect these incident non-communicable diseases. Adults living with HIV also have higher rates of important co-infections, such as chronic viral hepatitis viruses, CMV infection, or other comorbidities such as hypertension and depression, which may predispose them to other non-communicable diseases. Importantly, we note that even with effective antiretroviral therapy, adults living with HIV still have ongoing changes in their immune system, which can underlie a number of these comorbidities. We know that markers of HIV disease, such as CD4 nadir or CD4-CD8 ratio, as well as measures of T-cell activation, senescence, and systemic inflammation have all been associated with the onset of these non-communicable diseases. Further, while antiretroviral therapy is expanding life expectancies, we also know that many of, especially of our older drugs, carried a high burden of toxicity. The older antiretrovirals, the D drugs, as well as protease inhibitors and tenofovir have all been associated with the long-term development of some of these non-communicable diseases, particularly related to bone and kidney disease. And finally, and importantly, we know that people living with HIV can be disproportionately burdened with social determinants of health, which are also linked to these important health outcomes. Lifetime experiences of discrimination, racism, homophobia, as well as exposures to alcohol, tobacco, drugs, as well as environmental exposures, socioeconomic, and nutrition have all been associated with the onset of these conditions in the general population. And again, our adults living with HIV may be even further burdened with these risk factors. And then again, on top of all of this, we have the underlying biologic processes of aging that are ongoing. So indeed, there's been a number of studies in this work describing the epidemiology of non-communicable diseases in adults living with HIV. And many of them have shown that adults with HIV are at increased risk for a number of these non-communicable diseases compared to their peers. Compared to similar uninfected counterparts, adults with HIV experience higher rates of cardiovascular disease, certain cancers, metabolic disorders, osteoporosis, renal disease, and liver disease. And additionally, we know that many of these conditions do not occur in isolation. And this means that adults with HIV have a higher rate of multimorbidity, or 2 or more of these chronic conditions that's shown there on the right in the graph, which demonstrate from a matched study of adults with and without HIV, the number of prevalent non-communicable diseases among middle-aged and older adults. And we see that adults with HIV have earlier onset and an overall higher burden of 1, 2, or 3 or more NCDs. Recently, the burden of non-communicable diseases, but multimorbidity, or the accumulation of multiple NCDs, has become of greater interest. And this study, again from the Nationally Representative Observational Consortium of the NIA Accord, included data on more than 22,000 people with HIV from across the US and Canada from 2000 to 2009. Overall, they observed an increase in the prevalence of 1 or more NCDs among older adults in care during the study period. And this is looking at from the year 2000 to 2009. And you see that growing increase in the proportion of adults in care with age-associated conditions rising during the study period. Not surprisingly, older age was the greatest risk factor for multimorbidity, as shown now on the graphs on the left. Interestingly, not only does the overall burden of multimorbidity increase with age, they showed that the overall burden of multimorbidity was higher in older adults in 2009 than compared to the year 2000. Indeed, in their multivariable analyses, later calendar year was associated with multimorbidity even after adjusting for age. Other observed factors associated with increased risk of multimorbidity in their analyses included individuals of white race, those with heterosexual HIV acquisition risk factors, and in this study, there was no difference by sex observed. Beyond demographics, other studies have investigated the risk factors for multimorbidity in adults living with HIV. Echoing observations of their association with NCDs generally, and building upon possible underlying biological mechanisms, a number of immunologic biomarkers have been associated with increased risk of multimorbidity. And this includes having a low CD4 cell count nadir, having a low CD4 to CD8 cell ratio, and again, measures of T cell activation and senescence. Additionally, HIV viremia and viral load itself has been associated with multimorbidity risk. And while not observed in the NA Accord study, female sex has been associated with an increased risk of multimorbidity in other studies of adults with HIV. Additionally, comorbid mood disorders and depression, which have been associated with non-communicable diseases in the general population, has also been associated with multimorbidity risk in adults with HIV. And here I show the forest plot of on the right of an analysis that we conducted on patients who are followed at the Vanderbilt HIV clinic, where we examined the association of prevalent mood disorder, including depression and bipolar disorder, and risk of incident NCDs, including their first NCD, as well as risk of multimorbidity with 2 or more, 3 or more, or even 4 or 5 or more NCDs in separate analyses. In these analyses, prevalent mood disorder was associated with an increased risk of their first NCD, and this remained pretty constant even after we adjusted for covariates listed below. Additionally, we found that prevalent mood disorders, which were present in approximately a third of all of our patients, were associated with a 30% increased risk of metabolic syndrome in particular. The association of depression and risk of multimorbidity may be an important clue for how we can examine the burden of NCDs among adults with HIV in the future. It highlights a challenge to us in research to think about multimorbidity in older ages through the lens of social determinants of health and to apply a life course methodology to our studies, recognizing that exposures and experiences early in life have important consequences downstream. Observational research, which relies upon medical records, have important strengths with regards to the documentation and validation of NCD outcomes, but they're often limited by only including individual level risk factor data. Indeed, we know that interpersonal, community, and policy factors all significantly affect exposures that contribute to risk of NCDs and multimorbidity. Further, we know that these social and ecologic exposures are not fixed, and future studies need to elucidate how time-varying and cumulative social determinants of health exposures can contribute to NCD risk in adults living with HIV. Given our trends so far, we know that the importance of this research is only going to increase as we look to the future. Research from the Netherlands published a statistical modeling study to predict the changing demographics and burden of multimorbidity anticipated in the national Dutch cohort of adults living with HIV. The shift in the age distribution is seen on the left, and their study predicts that by the year 2030, the median age of adults with HIV will be 56.6 years, and 73% of all adults in the Netherlands living with HIV will be over the age of 50. On the right is the graph that predicts the concurrent increase in comorbidity burden among this aging population. And I think we can anticipate similar graphs as we look forward in the US, as we know that these burden and challenges are only going to continue to increase here as well. However, another important challenge in this field is to recognize that NCDs and multimorbidity is not just an issue in high-income settings. Shifting our focus now to one more global, we know that non-communicable diseases such as cancer, cardiovascular disease, respiratory diseases, and diabetes are of increasing concern in low and middle income countries as well. In fact, NCDs are one of the world's biggest killers and accounted for 63% of deaths worldwide in the pre-COVID era. Importantly, 86% of premature NCD deaths, meaning that these are deaths that are preventable through public health and health system targets that specifically seek to reduce common risk factors such as tobacco use or unhealthy diet. 86% of these premature deaths are occurring in low and middle income countries. In fact, in 2013, the WHO endorsed the Global Action Plan for Prevention and Control of NCDs. What are the drivers of this high burden of NCDs in low and middle income countries? Well, one very important factor is the shifting age demographics occurring in many countries where improvements in life expectancy and reduction in birth rates have fundamentally changed the population. These graphs highlight the tremendous change in the population demographics that are currently occurring in Latin America. At the bottom, you can see the age structure of high-income countries, with the bulge of middle-aged adults in 2010 and the projected increase in adults over the age of 60 by the year 2050. The graphs at the top show the change in countries in Latin America from a population in 2010 that was disproportionately under the age 40 to the projected bulge of middle-aged adults and growing population of older adults that's expected by the year 2050. While individuals in low and middle income countries are living longer, other changes in exposures affecting NCD risk are also occurring. Indeed, the burden of NCDs and its risk factors in low and middle income countries are not just of interest in public health, but also in economics. This article, now from a few years ago, described the growing presence of unhealthy food options in Brazil. It showed familiar figures of rates of obesity, where we see the marked increase from 1980 to 2015, where in the US rates of obesity skyrocketed from 10% to 27%. However, globally, the rate of change in obesity has actually been greatest in countries in Latin America, Africa, and in Asia. In fact, in Brazil in the past decade, the obesity rate has nearly doubled to over 20%, and the proportion of people who are overweight in the country has tripled to 58%. Indeed, the growth of obesity in Latin America remains of high interest. And I highlight here just an article that was in the New York Times yesterday that was describing the cultural and even legal shifts in Brazil that's adapting to the explosion of obesity in the country. This article highlighted again that over the past decade, obesity has doubled to more than 1 in 4 adults in the country. And now the country is looking to enact new laws to help protect overweight adults from discrimination and to help them acquire accommodations that they need for their daily lives. Well, just as the press has noted changes in NCD risk factors around the globe, our HIV research colleagues from many low and middle income countries have been sounding the alarm for NCD research in adults living with HIV for a number of years. This special issue from JADES from 2014 was calling for the HIV research community to recognize the growing burden of NCDs in adults living with HIV in low and middle income countries. They noted that while the links between HIV, its therapies, and NCDs have been established in high-income settings, less has been described in low and middle-income countries where the majority of people living with HIV reside. Also, differences in local environment, genetics, treatments, and co-infections all may affect NCDs in people living with HIV globally. And public health infrastructure for HIV can be leveraged to improve the diagnosis, treatment, and outcomes of these NCDs in resource-limited settings. To answer that call, I want to first introduce a research consortium that's near to my heart, the Caribbean, Central America, and South American Network for HIV Epidemiology, or CCASANET. Like NA-ACCORD, which I introduced earlier, CCASANET is one of the 7 global regions that make up the International Epidemiologic Databases to Evaluate AIDS, or IDEA. These consortiums include and harmonize data from adults and children living with HIV and receiving routine clinical care from around the globe. At CCASANET, our focus is to understand the HIV pandemic in Latin America. And our data includes observational data of more than 47,000 people living with HIV in sites in Mexico, Haiti, Honduras, Peru, Chile, Brazil, and Argentina. And here at Vanderbilt, we support CCASANET by serving as the data coordinating center. In recent years, our group has become increasingly interested in older adults with HIV in the region. As in high-income settings, people with HIV in Latin America have been experiencing increasing lifespans as a result of antiretroviral therapy. And this is a recent study from our group, which was led by an internal medicine resident here at Vanderbilt, which used life tables to calculate life expectancy at age 20, using data from adults with HIV and attending CCASANET sites between the years 2003 to 2017. We examine life expectancy trends across 3 calendar periods and use regression models for calculation of mortality rates to account for likelihood of loss to follow-up. We looked at trends across key demographics and clinical factors at antiretroviral initiation. In total, our study included more than 30,000 individuals living with HIV. And since a large proportion of our cohort were individuals at our Haiti site in particular, which has a different HIV history compared to the other sites, we stratified our results by the Haiti site and all of the other sites in Latin America. Overall, we observed that for the Haiti site in red and all other sites in blue, a steady increase in life expectancy among adults who started antiretroviral therapy across the calendar eras. Using UN data of life expectancy at age 20 in 2018, shown in those triangle figures, those triangle designations in the figure, our final life expectancy estimates in the most recent calendar years were approaching those of the general population. Importantly, increases in life expectancy were observed across sexes and HIV acquisition risk groups. Additionally, we saw increases in life expectancy across CD4 cell count at initiation, shown in those top graphs, as well as a rise in life expectancy based upon presence of TB at ART initiation and by education below. While there's still much work to be done to narrow these persistent disparities, overall, the trend in increasing life expectancy among adults receiving antiretroviral therapy in Latin America is clear. The improvements in life expectancy really confirm the experience that our in-region collaborators were seeing in their clinics. Highlighted in a nice study by our colleagues in Mexico City, among CCASANET clinical sites, we have observed an overall increase in the proportion of patients over the age of 50, from 8% overall in the cohort in the year 2000 to 24% in the year 2015. The rate of this demographic shift has been steady across calendar era, with some of the steepest slopes from those sites in low income settings, such as Honduras in the purple line and Haiti in the green line. Looking more closely at older adults in our cohort, Dr. Belanzaren, also from the Mexico City site, led a study to look at the prevalence of comorbidities in this population. This study included more than 3,400 adults in the cohort who were over the age of 50. And then we stratified this analysis by those who enrolled in clinical care before the age of 50 and aged into their 50s while in care versus those who were diagnosed or entered the clinic after the age of 50. We calculated the annual prevalence of one or two or more key comorbidities. Overall, those adults who enrolled in the clinic after the age of 50 were followed on average for about 4.5 years, while those who enrolled at a younger age and then aged into the over 50 category had an average follow-up of nearly 11 years. Overall, looking at the graphs, we see that adults who aged into older age had a number of prevalent comorbidities at the age of 50. They had a higher number of prevalent comorbidities at the age of 50 compared to those who entered care after the age of 50. And why is there that difference at baseline? It could be that those who entered care at a younger age had a longer time to experience the effects of HIV infection and its treatments, and then therefore develop the non-communicable diseases. Or it could also reflect differences in healthcare encounters and opportunities for diagnosis of these comorbidities between the two groups. Regardless, by the end of follow-up, the two groups had a similar average number of comorbidities. So regardless of when older adults started engaging in HIV care, by the end of their follow-up time, roughly a quarter had at least one chronic comorbidity, and another 25% or so had two or more comorbidities. Our experience in trying to study non-communicable diseases in Latin America has brought to the forefront a number of important challenges. And while some of these may be more marked in low and middle income settings, they certainly are still present in high income settings as well. Overall, when studying these outcomes, we know that there may be differences across countries and regions with respect to underlying life expectancy or ART policy history. There's often incomplete capture of social and behavioral risk factors in medical records, and there's often limited information on key aging outcomes related to multimorbidity, like quality of life or geriatric syndromes. However, probably the biggest challenge we face is concern about missing and misclassified non-communicable diseases using only HIV medical records as our source. We face the challenge that an absence of evidence is not actually an evidence of absence. Missing and misclassified NCDs in the data can result due to differences in screening and diagnosis, such as what may occur when patients receive their primary care at other locations and their HIV care separately. Additionally, there can be differences in medical record systems, such as paper or electronic medical records, which can affect capture of these important endpoints. To address this limitation specifically, investigators at CCASANET tried to narrow the focus a bit, and we tried to focus specifically on what's been happening in Brazil. For a number of years, I've been involved in studies specifically on non-communicable diseases occurring in adults living with HIV in Brazil. And Brazil is an important setting to study HIV, as it was one of the first middle-income countries to make antiretroviral therapy free for charge to individuals living with HIV back starting in the 1990s, and it was an early adopter of the treat all era. The largest country in Latin America, it has an estimated 900,000 people living with HIV, and through its public program providing antiretroviral therapy, data from 2017 showed its progress toward meeting the 90-90-90 goal in HIV treatment including having 84% of individuals living with HIV diagnosed, of whom 75% had started antiretroviral therapy, and of whom 92% had achieved virologic suppression. So with that background, in 2014, CCASANET received a supplement from the NIH to study NCD outcomes among ART recipients in Brazil. We partnered with COORTE Brazil, which was an existing multi-site observational cohort study that was founded by the Brazilian government to examine clinical outcomes following antiretroviral therapy initiation. For our CCASANET project, NCD diagnoses were collected and validated using medical record data from 7 clinical sites located in 6 major cities across the country. Clinical staff abstracted NCD diagnoses from the medical records, which were then internally validated by physicians, and sites underwent additional external data audits for data quality assessments. In our analysis of multimorbidity, we included more than 5,500 adults who had initiated ART, whom contributed more than 20,000 person-years of follow-up. The cohort was about a third female, and the median age at antiretroviral therapy initiation was 36 years. The median CD4 cell count was a little over 200, and nearly 70% of the patients started a non-nucleoside reverse transcriptor inhibitor-based regimen. Overall, 5% had one prevalent NCD at the time of ART initiation, and the median follow-up time was close to 4 years. Among all patients included, there were nearly 1,000 incident NCD diagnoses, the most common of which was lipid disorders or hyperlipidemia. The second most frequent NCD was diabetes, followed by osteoporosis or osteopenia, and the other NCDs occurred at lower frequencies. We first examined the incidence trends of these individual NCDs. And while most NCD diagnoses remained relatively stable during the follow-up period, we observed a trend in decreasing rates of hyperlipidemia in the top line, an increasing rate of diabetes shown in the red line, and a rising rates of osteoporosis and osteopenia shown in the orange line, likely related to changes in screening practice. While many of the individual NCD rates were stable, the rate of multimorbidity increased during the study period. Shown in the graph on the left is the proportion of patients with 2 or more NCDs in the black bars and 3 or more NCDs in the dark gray bars. And we see those numbers increasing parallel to the increasing proportion of person time in the cohort that was comprised of adults age 50 or greater. In fact, by the year 2014, more than 20% of the cohort was over the age of 50. On the right, we show the cumulative incidence of multimorbidity in the cohort, showing that by about 10 years following ART initiation, 10% of patients had NCD multimorbidity, with rates higher in females compared to males. In addition to sex, we observed risk of incident multimorbidity was higher for those who were older at antiretroviral therapy initiation, those who had a lower CD4 nadir, those who initiated ART more recently, and also those who had at least one NCD at the time of ART initiation. These results underscore not just the growing burden of multimorbidity with aging adults receiving antiretroviral therapy, but also underscores the importance of early HIV diagnosis and initiation of ART. So going back to our challenges, while our work with COORTE Brazil attempted to reduce some of the first 2 limitations to NCD research, we're still limited by the final 2, a lack of standardized social and behavioral factors, and no information on aging outcomes downstream of multimorbidity, such as effects on quality of life, physical function, cognition, and geriatric syndromes such as frailty. The field of HIV and aging has increasingly focused not just on NCDs, but important geriatric syndromes and adverse outcomes such as frailty. And that's because we know from clinical studies that older adults with HIV and multimorbidity in particular experience a higher risk for not just frailty, but also risk of hospitalization, decreased measures of quality of life, increased likelihood of polypharmacy and healthcare utilization, and increased risk of cognitive decline. Importantly, our knowledge of these geriatric syndromes has increased significantly in high income settings, but very little has been reported from low and middle income countries. Additionally, while we know that social and environmental exposures are critical for the outcomes and may differ in low and middle income countries, we also hypothesize that differences in chronic co-infections may affect NCD and aging outcomes in older adults living with HIV in low and middle income countries. This figure shows just some of the pathogens prevalent in many low and middle income countries that can affect the cellular mechanisms of aging, which in turn drive the pathogenesis of NCDs and cumulatively the onset of geriatric conditions. Looking forward to the future, our group in CCASANET and partnering with collaborators from COORTE, Brazil, hope to provide important information in this space, examining how social determinants of health and co-infection together affect aging outcomes in older adults living with HIV in low and middle income countries. We were recently funded by National Institutes on Aging to build a prospective cohort of older adults with HIV in Brazil to collect longitudinal data on comorbidities, particularly cardiovascular disease, as well as geriatric syndromes, including frailty, physical function, disability, and cognition. We will collect systematic information about social support and socioeconomic factors such as food insecurity, as well as behavioral data to investigate both the immunologic effects and consequences of endemic co-infections, as well as social determinants of health that can affect the biological mechanisms of aging. The study is just getting started, and so hopefully I can return to UAB in the future and update you on our results. So just wrapping up, I know this has been a little bit of a whirlwind, but I hope that I've shown that older adults with HIV are increasingly becoming the majority of the patients that we're caring for in our clinics. And this is happening in low and middle income as well as high income settings alike. Improvement in lifespan have occurred, but we have a lot more work to do to improve health span of adults living with HIV. The burden and causes of NCDs and multimorbidity in these patients are complex, and they include long-term effects of HIV virus, its treatments, and other factors. Importantly, our understanding of the roles of social determinants of health and how they affect these aging outcomes is incomplete. More research into the epidemiology of NCDs and multimorbidity among people living with HIV in low and middle income countries is needed. And addressing limitations inherent to this research is needed, as well as recognizing the unique exposures, risk factors, and strengths of these settings. I hope I've shown you that collaborative research across the globe can lay the groundwork for this important work to be done. I want to take a minute to recognize my team here at Vanderbilt, all of these investigators and partners here work to help support CCASANET and help to lead some of these studies. I'd also like to recognize and thank my collaborators really across the hemisphere and co-authors on some of the studies that I presented today. And from Nashville, I thank you for your attention today, and wish it could have been in person, but thank you for the opportunity to share.